Hey guys, welcome back. The agenda for today's discussion is to talk about MVP, that is mitral valve prolapse. The impression on reading the word prolapse per se would be that the structure would go down, but what really happens in this condition, and I'm just going to zoom into this diagram, is to represent that the valve would be bulging in an upward direction, which is also referred to as the billowing of the valve, or you would have also read multiple times an alternative term to describe this condition, floppy valve syndrome. The problem in this condition will be manifold. You see, once the valve will bulge much higher than normal, there's also a possibility that between these defective valve leaflets, there might be leakage of blood from LV to LA. That will contribute to development of even a murmur that will be called as a late systolic murmur, and I'll hand draw that murmur subsequently before you. But the message is that in the exam they can be writing alternative terms just to throw you off the track. There are three names for the same disease: mitral valve prolapse, floppy valve syndrome, and Barlow syndrome. The highlight of this disorder would be lax or loose chordae tendineae. These lax or loose chordae tendineae are going to be supported by the papillary muscles, but now the papillary muscles will be having to do extra work so that they can keep this infrastructure intact, in a sense that they are trying to prevent leakage of all the LV cavity blood from going into LA, because all this blood is actually meant for the aorta. You see, during systole, in you and me, when the left ventricle contracts, not a single drop of blood is ever gonna leak from LV to LA. But in these patients, the two things would be happening. That is, first the bulge, and then there's a defective coaptation of the valve leaflet. So if these valve leaflets get separated, you might even be having a variable amount of blood leaking. And in the later phases of the same disease, there can even be dilatation of the mitral valve annulus. So this can get converted into frank mitral regurgitation. Therefore, as a result of the statement that I said, you will always read this MCQ that overall, what is the most common cause of development of mitral regurgitation of the primary variety? I've recorded mitral regurgitation separately, so you can listen to it. But the number one cause is the topic that we are studying, mitral valve prolapse in Western countries. Now, he specifies the word Western countries because obviously in India, rheumatic fever, and developing countries anyway, rheumatic fever will be relatively more common, and therefore valvular regions would be common. But in the exam, we will follow the Western data, what Harrison says. And once we've understood that this disease per se can contribute to MR, then we will also understand why it is developing in the first place. You see, I said two things. One, it is contributing to MR, but why is it occurring in the very first place? Because that would also be the query from your patient that, sir, why me? So you would be telling this guy that there is an unfortunate idiopathic, in fact, that's a very liberal term that doctors use, idiopathic, but it has been documented that there is a myxomatous degeneration. We really don't know why this is happening, but we have documented that there is a problem, right? And what's the problem is that there's a defect of type 3 collagen. So electron microscopy studies in this case have shown structural damage, or it has shown fractures or microfractures developing within the myofibrils of the muscles per se, of the cardiac muscle. So there's a myxomatous degeneration of the mitral valve apparatus. And in fact, lots of time you will notice in multiple choice questions, idiopathic word will not be given, and it would be myxomatous degeneration as a terminology that would be referred. And it's a defect of type 3 collagen, as I highlighted originally. So this would be the number one reason. Over and above this, it can be associated with connective tissue disorders also. One of the important connective tissue disorders that you are familiar with is related to defect on chromosome number 15. The protein that is defective here happens to be fibrillin 1, and these patients can not only be having a MVP, but they can also be having aortic root dilatation. They can even have a aortic dissection. In fact, you very well know that in Marfan syndrome, where the height of the patient will be fairly substantial and the arm span will be more than height. In you and me, the height is more than the arm span, but in this person, the arm span will be more than height. They can be ectopia lentis, and these patients can have aortic dissection, which can contribute to death as well. Then another connective tissue disorder is referred casually as rubber man syndrome. This would be Ehlers-Danlos. So this condition will anyway be having hyperextensible joints, and therefore these patients can actually extend their joints to, I would say, very outrageous angles, to the level that they might be participating even in Guinness Book of World Records, and the person might be doing a I would say extension of the wrist joint, or they would be contorting their body and maybe fitting their body into a glass box, which is impossible for a normal person to get into. Then a fourth reason that's to be remembered is osteogenesis imperfecta. You read about this in pediatrics with the blue sclera and multiple fractures in a child. So lots of time in pediatric age group only, they could be expiry of the patient. But then there are a couple of variants where you not only have a aortic root dilatation, but even a mitral valve prolapse. It is similar, like I said, in Marfan syndrome, you have a aortic root dilatation. It's also written in osteogenesis imperfecta literature, the same data, aortic root dilatation and even a mitral valve prolapse. For point number 5, I would like to say that you are all aware of a term in emphysema, barrel-shaped chest. Barrel-shaped chest would mean that the antero-posterior diameter of the chest would become more than the transverse diameter. You see, in you and me, what is happening is the thoracic, or I would say the shoulder-to-shoulder diameter, that is the transverse diameter, is more than the AP diameter. The bottom line is, in a normal individual, transverse diameter, that's going to be shoulder to shoulder diameter, is more than the anterior-posterior diameter. That's okay. But what I'm saying is, if the anterior-posterior diameter, whatever is present for you and me, you can measure it by putting your hand in your axilla. That's your anterior-posterior diameter. If the anterior-posterior diameter becomes even lesser than normal, if the AP diameter becomes substantially lesser than normal, then the heart will be compressed. In fact, this condition that I'm describing before you will be having a fundamental problem, that the thoracic kyphosis is substantially reduced. So in American books, it is written pancaking of the heart. That's the heart is compressed between the sternum and the vertebra. The anterior-posterior diameter of the chest is reduced. So the term that they will use in the MCQ to describe this entire description of point number 5, back syndrome. The meaning of this, explain once again. Straight back syndrome means that the space available for the heart between the sternum and the vertebra is substantially reduced. The AP diameter becomes lesser, whereas I also explained a condition by the name of barrel chest in emphysema, where the AP diameters symmetrically, or I would say disproportionately increase as compared to that of a normal individual. The complete diametrical opposite issue is straight back syndrome, is the reason why I have highlighted it here. For point number 6, because in developing countries anyway, rheumatic fever will be one of a common disease. So there could be Ashkoff nodules which could be occurring at the junction of the chordae tendineae with the papillary muscles. These Ashkoff nodules could be causing damage to chordae tendineae to the level that they might even be a chordal rupture. You see, there's a limited number of chordae tendineae structures which are present on the undersurface of the valve. If any one of them will snap, then this caudal rupture can cause this disease to deteriorate suddenly into mitral regurgitation, and that is what happens in these patients. Some of these patients of MVP, they might remain asymptomatic for large number of years, and some patients can progress very fast. It depends on the etiology per se, but like I mentioned, Ashkoff nodules can be causing damage to the chordae tendineae to the level that they can snap. Similarly, even in subacute bacterial endocarditis, there could be damage, infective damage to the chordae tendineae, and therefore they can snap. Caudal rupture, frank mitral regurgitation, acute decompensated congestive heart failure could be occurring in the patient. In dilated cardiomyopathy, now the problem in dilated cardiomyopathy is multi-pronged, I would say. One of the biggest problems in dilated cardiomyopathy is mitral annulus will be dilated. So anyway, when I have discussed dilated cardiomyopathy, I have said person can be having tricuspid regurgitation, also have a mitral regurgitation. Why? Because the mitral annulus itself is dilated. Point number 7, I would say, is important from the pediatric domain. We are all aware of the fact that the commonest type of ASD that we encounter, commonest congenital heart disease, is VSD, but the commonest type of congenital heart disease that we study in Down syndrome is ostium secundum ASD. So even ostium secundum ASD can be associated with, you lots of time read the word cleft mitral valve, or it could even be mitral valve prolapse associated. So these are some of the important reasons why this would be happening, but we need to remember from the exam perspective, usually the number one reason why it happens and what would it contribute to subsequently, that would be a mitral regurgitation. And see, the bottom line is, it's not only a mitral regurgitation. If you are going to be having loose chordae tendineae, the papillary muscles will anyway be working much more than normal, and because they have to support the valve infrastructure. So therefore, what we also find in these patients in the long run is a component of subendocardial ischemia also develops. I repeat the fact once again, that chordae tendineae are either snapped or for that matter of fact they are loose or lax. Therefore, as a result of it, the papillary muscle will have to work harder to maintain the normal architecture. Otherwise, this billowing of the valve leaflet can contribute to a mitral regurgitation, acute decompensated left ventricular failure of the patient. So if the papillary muscles will work more, subendocardial ischemia will anyway be present in these patients, which explains the fact that why is it written that there could be substernal chest pain in these patients. That's not related to exertion, and a lot of these patients, because they have this chest pain, they might be taking antacids for a very long duration with no relief of chest pain. So every time you have a young female who complains to you of chest pain and even has palpitations, you are not only to think in terms of panic attack. I agree to the fact that panic attacks could be occurring definitely in a young patient, and the symptoms that are present in MVP can be easily diagnosed or misdiagnosed, I would say, as that of panic attacks or anxiety neurosis. So it's always a good idea that before you say to somebody that you have a panic attack or you're having anxiety neurosis and you're writing anti-anxiety medication for the patient, good idea to run an echocardiography to be sure that MVP is not missed. As far as the pathophysiology of the disease is concerned, I have verbally explained it, but for record purposes, I anyway have to jot it down also. So let's look at two fundamental problems that develop in mitral valve prolapse. The first and the foremost would be a defective coaptation of the mitral valve leaflets. What's happening here is that I said in you and me, the mitral valve leaflets are able to close so tightly that not a single drop of blood is ever gonna leak from LV to LA. But in this patient, the coaptation of the leaflets is affected, due to which there can be leakage of blood. And as I said, I mean, the chordated DNA will be stretched much more than normal. So when those loose lax chordated DNA are stretched, you see the valve is going up. So the chordated DNA is getting stretched like a rubber band. So the vibrations that are set up due to the sudden tension developing in the lax chordated DNA. I repeat my statement. Due to when the valve is going up, the chordated DNA is getting stretched. So said due to sudden tension that develops in the loose chordated DNA, there could be auscultatory finding that develops in this patient, and that's one of the main reasons why we are studying that. That would be mid-systolic clicks. This is what I said. I said lax chordated DNA would be, and the reason for lax, I mean, you know, after all, because I'm introducing this word again and again, why is it lax? Why is it loose? Myxomatous degeneration. Because patient will always ask you, sir, why are they loose in you and as compared to you? I mean, why am I having this defect? So it's a myxomatous degeneration or even rheumatic fever, endocarditis aspects that I explained to you. So there is undue stress on the papillary muscles. They are working harder to maintain the normal infrastructure, and therefore subendocardial ischemia can occur, which explains chest pain. They can even be tachyarrhythmias in this condition. So sudden cardiac death risk is increased in MVP. I've told you sudden cardiac death in MI, in patients who are having hypertrophic cardiomyopathy. Any cardiomyopathy, there could be tachyarrhythmias, they can be risk of sudden death. But you can add one more condition for SAD over and above aspects like Brugada syndrome, arrhythmogenic right ventricular dysplasia, cardiomyopathies. Mitral valve prolapse is also added to the discussion. So I will now be making a list of the clinical features in these patients. As I said, most of the time gender is gonna be female, 15 to 30 years of age. It can occur in men also, but usually it has been found that in men, MVP is around about 50 years of age, and the severity of disease is more in men as compared to women. And well, what is the first presentation? Then I can say in large number of cases, the disease might remain asymptomatic initially because there is no leakage of blood from any chamber of the heart to a low pressure chamber. So no issues initially. But as the stress on the chordated DNA and on the papillary muscles, and there's a subendocardial ischemia component developing, which I explained in pathophysiology. So a lot of these patients will say that, doctor, even when I'm sitting on a chair comfortably, I feel as if my heart is racing. I can feel my heart beating fast in my chest. In fact, in these patients, if you run a ECG, you will be able to identify a very common rhythm disorder. In fact, this is itself a question. What is the common rhythm disorder which can be identified in MVP patients? Then your answer would be premature ventricular contraction. Let me just quickly sketch it before you. What's happening in PVCs would be, this is normal sinus rhythm. Then there's a premature ventricular contraction, a broad QRS complex. So because the ventricle will contract early, It will not get time to get filled with blood properly, because after all, you see, heart has to relax properly, then it will get filled with blood, then it should contract. If you're gonna be having a premature contraction, the ventricle never got time to get filled with blood. So if input is less, output will also be less. So these patients will develop another complaint also, which would be in the form of dizzy spells. So here, with help of ECG, I've just tried to highlight that every time there is a PVC in the premature ventricular contraction is bad, in a sense that there is a less output from the heart, so recurrent syncopal attacks can occur. So for these patients, they'll say like, it's an embarrassing situation. I went to a marriage party, I was sitting with my friends, and some of them invited me for a dance. I tried to dance and I became unconscious. Why? Because there was a PVC event that was happening in these patients. In fact, there's also a possibility that these patients can go and develop a frank ventricular tachycardia, in which all you will get is premature ventricular contractions again and again and again, and the heart rate will be more than 100. In fact, in some of these patients, it's even a possibility that because the LV blood will be going to LA, so there would be structural dilatation of the LA, there would be structural damage to the left atria, and the structural damage to the left atria can trigger a atrial fibrillation. And what I've done in the ECG of this patient is that I have tried to highlight a very characteristic variable RR interval. Now, if you look at this ECG, though I have discussed the ECG component separately, you will notice that the RR interval in the ECG of the patient is not constant. The RR interval is changing. So you can not only be having ventricular tachycardias, but you could also be having atrial fibrillation developing in patients of MVP, thanks to the structural damage to the left atria. As I explained, the subendocardial ischemia, primarily due to the undue stress on the papillary muscles, will explain the substernal chest pain, and this is not related to exertion. I mean, initially you might think that suppose a 50-year-old guy, let's say a gender male, is coming to you and he says, sir, I'm having chest pain. You will think that, okay, on walking, how much distance do you get chest pain? Because you thought it could be triple vessel disease, and he's having chest pain on exercise. And he says, no sir, I don't have chest pain on exercise. Even sitting on a chair, I'm having chest pain on a regular basis. So I said, what did you do about it, sir? I've taken antacids, I've shown so many doctors, but nobody has given me a conclusive reason why I have suffering from chest pain. I even got an endoscopy done, because most of the time when you have substernal chest pain, and especially in a younger patient, in older patient the investigations will be more aggressive. In a younger patient, if somebody is having substernal chest pain, a lot of these patients might be actually subjected to endoscopy, might be taking pantoprazole on a regular basis, but no relief. And then another feature that can develop is damage, because you see, after all, the valves are suffering from undue stress, so therefore there could be development of valvular endothelium damage. Now, once the endothelium is damaged, the platelets will be obviously attracted to this. I mean, endothelial damage is anyway like is gonna be acting like a magnet for platelets. So valvular endothelial damage can contribute to formation of miniature platelet plugs on the valve, and these platelet plugs, when the valves will open and close, the shearing stress will cause these platelet plugs to go into systemic circulation to brain, and patient might be having a TIA. And the same young lady saying, sir, I woke up with severe weakness in my arm. So I thought that I had slept over my arm. You know, there's a possibility that sometimes if you're sleeping deeply and you're sleeping over one arm, you might wake up with, you know, as if the arm is numb. So she says, sir, I thought that this is the case, but then this has happened not once but multiple times. And it's not that I was sleeping on that particular arm. I just woke up with arm weakness, and thankfully the weakness resolved on its own, because it's only a platelet plug. It was not a fully developed thrombus. So TIA events can also be reported in these patients, and it's not only a arm weakness. It could be speech defects, it could be facial weakness, which can be reported and in the exam, because anyway they love to ask about atypical aspects, so they can mix up this information. You see, if you read about a young female having recurrent episodes of palpitations and dizziness and chest pain, you might think in terms of panic episodes, you might think in terms of anxiety, but that is always a diagnosis of exclusion. No, you just can't tell somebody because that you are having these complaints, I think you are having anxiety neurosis. You must subject the patient to echocardiography, and especially if neurological features are present, you have to be even more alert to this particular condition, and so that you are able to pick it up relatively better. Then the incidence of infective endocarditis is any valvular lesion. Infective endocarditis risk will be increased. I've already explained sudden cardiac death risk is also increased in these patients. I'll enumerate verbally the conditions for sudden cardiac death that I'll be describing in the app. It can be arrhythmogenic right ventricular dysplasia. No big deal. Arrhythmogenic word is written. Brugada syndrome, discussed subsequently in the app. Then could be all cardiomyopathies, myocardial infarction, and MVP is added to that list. And the worst case scenario is that the person never got identified. Then patient will develop mitral regurgitation. There's a caudal rupture. The papillary muscles will not now, because after all, there are limited number of chordae tendineae. If couple of chordae tendineae are snapped, just imagine you cutting some of the chordae tendineae, the valve will not be able to retain its position, and a very large volume blood will now be leaking from LV to LA, which will contribute to development of acute decompensated congestive heart failure. Frank pulmonary edema will develop in this patient, and there is even a possibility that pink frothy sputum might develop so fast that these patients might even die as well, though this is in only those cases which are grossly neglected and have not been diagnosed. So let's have a look at now what are the examination findings that you will be encountering for identification of this condition. And the main reason for development of this auscultatory finding would be development of tension in those loose and lax chordae tendineae. The reason why they're loose and lax is due to the myxomatous degeneration. Once they get tensed up, the vibrations that are set up result in development of mid-systolic clicks. When I'm writing the term mid-systolic clicks, I don't want you to ever confuse this with ejection clicks, because ejection click is a perfectly normal finding. You see, when I have described normal cardiac cycle in heart sounds, I have talked about ejection click, which is going to be opening of the aortic and the pulmonic valve. But this time, this patient is having these mid-systolic clicks. Why? Because of the tension that is developing in the slack chordae tendineae. You see, if these chordae tendineae will rupture, at the moment they are still holding their position. If they rupture, this would be disaster in making. Mitral regurgitation can occur, and then you would be having a murmur which will definitely change character. So let me just draw this before you. You see what I have done diagrammatically here is represented the normal heart sounds. I said this is ejection click, perfectly normal. And you're gonna be hearing what is called as mid-systolic clicks in this patient, because the chordae tendineae are not one. There's no single chordae tendineae. There are multiple, many of them. So lax chordae tendineae are getting stretched one by one. That's why mid-systolic clicks. And then another event will occur, which is that they may not be able to ensure that the valve might remain tightly approximated. The valve leaflets, the coaptation part will also be hampered. You see, valve is going up, separated. Blood is leaking, so there might even be a development of a murmur, and this murmur is to be remembered because this is developing in the later part of the systole. You see, the period between S1 and S2 is systole. You can see the murmur is starting almost in the later part of the systole. The intensity is rising and then is falling. So the technical term, that's the second auscultatory finding of this patient, would be a late systolic murmur. But if he wants to make life difficult for you, the examiner can write the word late systolic crescendo decrescendo murmur. When you read this term crescendo decrescendo, there's a high probability that you might actually confuse this with the murmur of valvular aortic stenosis. I'll draw the line diagram also, but at the moment I want to say that if a person is having valvular aortic stenosis, in those circumstances, when you hear the murmur, let me say this is S1, S2, S1, the murmur that will be developing in this patient will be starting right in the initial part of the systole, peak in the middle. You can see the peak is occurring in the middle. So it will be called as a mid-systolic murmur. But because if he says the word mid-systolic, it's going to be a piece of cake for you, because words are grossly different. No, on one hand, I'm saying late systolic, then I'm saying mid-systolic. So easy differentiation can be made. So he will just use the word in this MCQ of aortic stenosis, crescendo decrescendo murmur. If he writes this word plain crescendo decrescendo murmur, it's gonna be valvular aortic stenosis. The technically more appropriate term is mid-systolic murmur for valvular aortic stenosis. But do remember, if it's gonna be mitral valve prolapse, the murmur is gonna start after these mid-systolic clicks. The valve leaflets are gonna be going higher than normal. Chordae tendineae are getting stretched. The vibrations that are set up in those lax chordae tendineae explain this finding. And then there's a defective coaptation, blood leaks, so you get a murmur in this patient. Let me just draw a couple of line diagrams so that this concept can become much more clear to you. So please be patient, and if possible, just it will just take 30-40 seconds of your precious time. So just try to hand draw with me. What I have done here is deliberately exaggerated the findings, because you see, in you and me, when the left and the right ventricle will contract together, 80 ml blood is gonna rush into the pulmonary artery, 80 ml blood is gonna rush into the aorta, and you can very well see that due to the pressure generated, there will be a slight bulge of the tricuspid valve in upward direction. But see what is happening in case of mitral valve, it is bulging much higher than normal, and all the chordae tendineae that are shown colored in now in pink color are on the under surface of the valve. They are suffering from undue tension. As a result of it, this pressure will also be, or this tension will also be transmitted to the papillary muscles which are attached to this. And as a result of this papillary muscle suffering from undue stress, I said subendocardial ischemia can definitely develop in these patients. The height of by which the mitral valve goes much higher over the mitral annulus. Mitral annulus would be baseline value is about 2 millimeters or more. So what you can see at the moment is I've not shown any leakage of blood. All I said is more tension in these lax leaflets, so you get a mid-systolic leg. But if same thing happens, let me say 60 times per minute, 7 days a week for next 10 years, then no big deal that a limited amount of blood might start leaking also in the later part of the systole. So that's why I said late systolic murmur, and if the patient deteriorates further, it will anyway get converted into mitral regurgitation also. Now let us compare this with the line diagram of valvular aortic stenosis. In this particular case, I'm gonna make the aortic valve relatively narrowed. So the left ventricle will exhibit a compensatory hypertrophy. Now when the hypertrophied left ventricle will generate more force, so I've shown 2 pluses here, the turbulence that's going to be created by sending blood into the aorta will be so much that you will be even able to feel this turbulence over the carotid artery of the patient. You get a carotid thrill, no? So in valvular aortic stenosis, the turbulence is going to be felt during the phase of systole. The movement the systole will start. You see on the contralateral side, no hypertrophy. When the right ventricle will contract, the blood will be smoothly flowing into the pulmonary artery. But you can notice a lot of turbulence on the left hand side. So the murmur that will develop in aortic stenosis, I'm just going to hand draw this before you here, is going to be a ejection systolic murmur. The intensity will rise and fall. But when it comes to MVP, I highlighted this. I am deliberately doing this, guys, and do this with me because visual memory is very important for doctors. In fact, doctors are supposed to have a photographic memory. So in the exam, if they give you a murmur which is going to be in the later part of the systole, crescendo, decrescendo, written or not written, really does not matter. At this moment, the keywords are late systolic versus a mid systolic murmur. You see, if you read casually, they might look the same, but you can see there's a huge difference between the hemodynamics of the left and the right hand side. So I would definitely like you to just hand draw this once quickly so that you are able to retain this information. Otherwise, it's a pretty straightforward information. I mean, you can obviously understand this without the line diagram also, but once you hand draw it, and you are yourself imagining, okay, the heart is contracting, what valve will open first, which valve will have to retain its position, so you will be having a much better orientation of the disease. I have at the moment explained to you the fact that there can be 2 findings, mid-systolic leg and a late systolic crescendo decrescendo murmur. Now I am gonna say that mitral valve is a bicuspid valve, and most of the time in this disease, posterior leaflet is more commonly involved than the anterior leaflet. Though obviously both leaflets can also be involved, so we can call it a floppy valve, flail valve, but posterior leaflet involvement is much more common as compared to the anterior leaflet involvement. Now let us see what's the implication of that. A bit of fluid dynamics, a bit of physics coming in. Incidence wise, I have written posterior valve involvement is more common than anterior leaflet involvement with respect to the mitral valve. If the posterior leaflet is defective, then what happens is that the jet of blood that is created, I showed about the blood leaking from LV to LA in the previous diagram. I'll just show that. I'm talking about this blood leaking. Then this jet of blood, if the posterior leaflet is defective, tends to move anteriorly. Just remember this fact that If he says the word posterior leaflet and he says where will the jet of blood move, you will use the opposite word. The jet of blood will move anteriorly. In contrast, if the anterior leaflet is damaged and he says the jet of the blood will be moving in which direction, then you will say that it will move posteriorly. So you just need to invert. I mean, for anterior, posterior, just invert the words. Now, what is the clinical significance of this? The clinical significance is that if the posterior leaflet is involved, the jet of blood moves anteriorly and this causes murmur radiation. Because after all, they love to always ask you about where would this murmur radiate. Like you see in previous statement of mine, I was saying in aortic stenosis the turbulence will be going up to the carotid artery. So you always read in aortic stenosis murmur radiates to carotid. Similarly, like you read, I repeat the statement, in aortic stenosis the murmur radiates to the carotid. Similarly, here you will read the murmur will be radiating to the base of the heart. Now all this is based on fluid dynamics, so it's not that I would say it's a little I would say that it might look intimidating initially, but then once you start reading the information again and again, it becomes routine for you. If anterior leaflet is damaged, the jet of blood moves posteriorly and this will contribute to murmur radiation occurring towards the axilla. And why that is important is because mitral regurgitation murmur also radiates to the axilla. So there can definitely be error of judgment on the part of a doctor, because if you just focus on the fact murmur is radiating to axilla, you might think he is talking about mitral regurgitation, but mitral regurgitation has a pan-systolic murmur, whereas this particular patient is having a late systolic crescendo decrescendo murmur. So therefore the wordings are very, very important. And now what I'm going to do is that I'm going to ask this particular person to stand and squat. I will explain the fluid dynamics once again, but at the moment I just want you to remember, if you look at this schematic diagram, what is happening is that when this person will stand, on standing the venous return to the heart will reduce. If there would be less blood coming into the heart, the prolapse tends to increase. Actually, prolapse is opposite to the size of the ventricle. I'll write that information down in a while. But the message is that the length of the murmur increases when the person is standing. And when the person will squat, you can see that the length of the murmur will become relatively lesser. Now, how to remember this? Simple. You see, if you are standing and then if I ask you to squat, if you squat, your height will become lesser. If you're sitting down or if you're squatting, your height will become lesser. So, shorter duration of murmur. When you will ask the patient to stand, then the duration of the murmur will increase. So, the message here is simply the fact that we are trying to go in for dynamic auscultation and we are trying to check for the duration of the murmur with respect to the standing and the squatting part. So, at the moment, I'll just write down the interpretation, the explanation I'll give in the next slide. In dynamic auscultation, when you ask this patient to squat, you will always notice that the duration of the murmur tends to become lesser. And when the person will stand, then the duration of the murmur will become relatively increased. Let's knock some more sense into it. So to understand this, the basic point is that prolapse that occurs of the valve in upward direction is actually inversely related to the size of the left ventricle or the right ventricle. Instead of writing it the way it is written in the textbook, size of the ventricle, I'm just writing it is inversely related to the volume of the blood in the ventricular cavity. Now let's see what really happens. Suppose I am asking this MVP patient to stand, then there would be pooling of blood towards the extremities, so venous return will be lesser. If the amount of blood coming towards the heart will be lesser, the cavity of the left ventricle as well as the right ventricle will be receiving less blood. Because I'm saying less blood, the volume of blood inside the ventricle will be lesser, and because there is an inverse relation between the volume of blood and the prolapse, this prolapse will increase. Because of this increase in the prolapse of the valve, the mid-systolic click will occur relatively early. And now I will be shifting the slide and moving back to the previous one. Because I said the mid-systolic click will occur relatively early. See what is happening in this particular case. When he's standing, this mid-systolic click, which is shown in red, is occurring relatively early. So therefore the duration of murmur is increased. On the other hand, let me do it again. It's good that I'm toggling between two slides so that your focus is on. So listen to now what I say opposite of what I've written. When I will ask this individual to squat, this is going to contribute to increase in the venous return. So more blood is coming to the heart. If more blood will come into the heart, the cavity size will increase. And I told you that volume of blood has an inverse relation with the prolapse. So this time the prolapse of the valve leaflet in upward direction will be lesser. The prolapse will be lesser. the mid-systolic click will occur relatively late. You see, mid-systolic click simply is due to tension. If the prolapse is lesser, that means that the tension will take some time to develop. So I wrote here that the mid-systolic click will occur relatively late, and that is what I've done in the previous slide. You will notice this in green that I've shown. This mitral valve prolapse mid-systolic click is occurring relatively later. So if there's a later aspect, the murmur will be having lesser time. If you can remember the logic here, great. Otherwise, I have already told you the hack with respect to dynamic aspects of auscultation, that they always would like you to remember not only the murmur but the impact of standing and squatting on the murmur of mitral valve prolapse. In fact, because they ask about other conditions also, so I'll tell you one more solution or a hack to remember this. And this statement of mine that I'm currently writing, I would suggest you to write it with me. The statement to be remembered, quoting Harrison, all murmurs decrease with Valsalva and standing. The logic is both with Valsalva and standing, there would be peripheral pooling of blood, so less blood will come in the heart, so all murmur intensity will reduce. Except there are two only exceptions. One of the exception to be remembered is HOCM. The second is the topic of interest, mitral valve prolapse. Now look at the difference. When it comes to the HOCM murmur, it becomes rather opposite. It becomes louder and MVP murmur becomes longer. Remember I told you, and when you are standing, you will be taller than what you are when you are squatting. So the murmur will become longer, and this longer and louder words itself can be, I would say, mixed up. So I would suggest you to definitely note this statement down and just put it somewhere so that you can read it a couple of times so that this becomes a permanent memory for you. We will now be focusing on the investigation of choice for this condition. That would be a transthoracic echocardiography. The echocardiographic criteria would be that the bulge of the valve should be at least, or I would say the minimum magnitude of bulge should be at least more than 2 millimeter above the mitral annulus. We can also do a transesophageal echocardiography in these patients, since a large number of cases might be requiring a mitral valve repair as well. So he writes in the textbook that we use a two-dimensional transthoracic echocardiography for identification, but if you have to identify more precisely the anatomical defects, is it anterior leaflet, posterior leaflet, both leaflets that are affected, and how would you plan surgical repair, because the surgeon needs to know beforehand what's the fundamental problem. So therefore more detailed information about the anatomy of the valve can be identified by transesophageal echocardiography. This is valid when you are planning a repair in a symptomatic patient. In case the symptoms are minimal, or I would say patient is asymptomatic, it was detected on annual medical checkup, then absolutely no issues, and a transthoracic echocardiography will be more than sufficient. If you run a ECG in these patients, there are two possibilities. One, you might be able to pick up evidence of subendocardial ischemia, which is presence of T-wave inversion. Like I have written here, T-wave inversion occurring in lead number 2, 3, AVF. So the examiner is simply trying to put pressure on you, especially for an old person. If he is describing T-wave inversion, you might start thinking in terms of chronic stable angina. But chronic stable angina is not going to be having auscultatory findings like the ones that I'm discussing, and impact of, I would say, standing and squatting on a murmur per se. So you would be able to differentiate. Another advantage of doing ECG would be to pick up PVCs, that is premature ventricular contractions. In fact, the commonest rhythm disorder that occurs in these patients, I'll just put it on record, the most common rhythm abnormality that occurs in these patients is PVCs. And if they occur serially, again, if there is PVC occurring more than 3 times and the heart rate is more than 100, it becomes a VT, a ventricular tachycardia. Then from research purposes in institutions, they might even be doing a cardiac MRI in these patients, because ventricular volumes can be estimated relatively better. MRI is anyway superior than echo, because you see volume is a 3-dimensional concept, and volume can be identified better with a cardiac MRI as compared to a echocardiography. And even invasive left ventriculography can be done in these patients. But I would say that When it comes to the investigations that I'm writing, these are only for academic reasons, or might be done in institutions to work out the special findings with respect to these patients, so that you can collaborate. Okay, these findings are related to what quantity or what magnitude of surgical repair that would be done in these patients. So, but routinely speaking, I would say that cardiac MRI or invasive ventriculography will not have too much of importance for identification of this condition. We will now be focusing on the treatment part per se. One of the important aspects is what would you do for the management of chest pain in this patient. So I'll be putting the patient on beta blocker. The advantage of putting the patient on beta blockers would be reduction in oxygen consumption of the heart, so the episodes of chest pain will reduce. And most importantly, if the patient is having palpitations, as I explained earlier, that palpitations part again comes because of rhythm disorder seen in these patients thanks to subendocardial ischemia. So to treat a combination of subendocardial ischemia plus palpitations, beta blockers would be more than sufficient. If you demonstrate some rhythm abnormality in these patients, like suppose atrial fibrillation is detected, then in those circumstances you will be deploying this score, which is discussed subsequently in atrial fibrillation, CHAD, S2, VSC score, and depending on the value, then you might be deciding to add oral anticoagulants for management of these patients. And anyway, since these patients are having TIA, if the TIA is initially milder variety, I would say, and it has not resulted in a full-blown stroke, then even low-dose aspirin might be started in these patients to prevent redevelopment of such episodes. Though, I mean, this is dependent on whether a TIA has occurred or not. In majority of cases, beta blockers and management of atrial fibrillation, especially from the perspective of preventing stroke, is definitely to be done. The main treatment for this patient would be mitral valve repair is any day preferred in these patients. Original valve is already always better than an artificial valve. So mitral valve repair will always be superior as compared to going in for a mitral valve replacement. And nowadays even transcatheter approaches are available, though these are, I would say, more of American concepts. Transcatheter repair, end-to-end repair is possible, and what they're simply doing is that there is a defective billowing valve, so they will excise the useless tissue and then put sutures to put the mitral valve back to its normal anatomy. And what I mean by normal anatomy is the coaptation of the two valve leaflets should be perfect, that there is no leakage of blood, because after all, what is happening in these patients is leakage of blood from LV to LA, and that is what I want to prevent. And if that is not prevented, it will anyway get degenerated into mitral regurgitation in the long run. And he also says that prophylaxis for infective endocarditis is to be done if previous episode has been documented. Now, obviously, I mean, if the patient has come to you first time and there is no infective endocarditis, there is no need for prophylaxis for infective endocarditis to be done. But yes, if these patients already had an episode and suppose this patient is going for a dental procedure, then prophylaxis for infective endocarditis would be warranted. So these are the aspects that I would like you to remember for this topic. And there's also animation in the earlier part of the app for this particular topic. So if you have a look at the animation now, I think it will make much more sense to you, and you will be able to retain the aspects that I've discussed, with the most important one being the auscultatory findings, which are casually missed, including the aspect of late systolic murmur, which I explained. So keep on working, guys, like this. You have made a phenomenal effort to come so far in the app and listen to all the discussions that are made, and continue doing this on a regular basis. I mean, 1 to 2 topics every day. Knowledge is power. Remember my words, knowledge is power. And the more you keep on hammering, the more you keep on focusing on a daily basis, you keep on building yourself up, definitely one day you will develop that skill where your eyes will automatically go to the right answer. It's not, I agree, exclusion skills are to be deployed, but then your eyes will start going to the right answer, and that comes with practice. And I'm very sure all of your brilliant chaps, you anyway have the capacity in you. It is just that you need to explore that hidden talent inside you to focus on all such aspects. Thank you so much for your patience and hearing me out.